Treatment, treatment, treatment. So dial in for me just for a little bit on this treatment because this is important here, okay? So when we talk about treatment, there's a 6-month regimen and there's a 9-month regimen. They're broken down and split into two different segments. In the 6-month regimen, you have a 2-month and a 4-month. In the 9-month, you have a 1-month and 8-month or a 2-month, 7-month segment. When we look at these, whether it's the first segment of the 6-month or the first segment of the 9-month, they have daily doses of bunch of meds. Okay, you have antibiotic, 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 antibiotic. You have all of these medications that the patient could end up on. 1, 2, 3, 4, 5 different medications that that patient could end up on daily for 2 months. Daily for 2 or 1 month. Okay, after they go through those first segments, they can move into a 4-month segment or a 7 or 8-month segment to where they're getting medications twice weekly. Now, I don't know about you, but I struggle even taking my vitamins regularly. And I don't have this life-altering disease that requires me to maintain my adherence to the regimen that the docs give me. So my non-compliance with my vitamins is awful. Now, I don't live in a shelter. I don't live in jail. I'm not homeless. I don't have a lot of the same struggles that the patients who are at high risk of getting TB, I don't have the same struggles that they do. So what do you think the likelihood is that they are going to remain compliant? Yeah, it's not very good. So what happens when you become non-compliant and you take antibiotics, you get a 10-day supply of antibiotics and you take 3 days of them? You end up developing bacteria that are antibiotic resistant. And that's why it's so important for when we get infection with a normal bacterial infection, not even TB, that we take the full supply of our medication so that the bacteria does not become antibiotic resistant. So one way that we've identified that we can get better results from our patients is we use what's called a direct observed therapy, or a DOT. And in short terms, this patient or this person is a accountability partner. And what they're designed to do is make sure that they recognize when that patient actually takes the medicine and you watch them ingest those meds. When we have somebody like a DOT that's on this patient's team, whether it's a family member, a loved one, whatever it may be, these patients end up doing better. The relapse rate decreases tremendously. The rate of drug-resistant TB decreases tremendously. So utilizing all of the opportunity, utilizing all of the information that we have is so important. Educating your patients on the importance of taking all of their medications for the duration that it's prescribed is so that we can understand that we're trying to do everything that we can to prevent these drug-resistant bugs from proliferating. Okay, I'm off my soapbox. Other things that we can do, we can give oxygen therapy, airway clearance, and mechanical ventilation. So we want to make sure that these patients are oxygenating adequately, maintaining saturations 90, 92 or better. Whenever they're in that fibrotic stage, maybe tinkering with the 88, 87 and better, just because they are going to have chronic hypoxemia, they're going to be chronic hypercapnic patients, so they may not necessarily need that 92 or better. But we can use nasal cannula, non-invasive ventilation, high flow nasal cannula, whatever it is to make sure that these patients are getting the appropriate oxygen therapy that they need. Airway clearance, we got to do everything that we can to help them eliminate any of those secretions to get those up. Mechanical ventilation, sometimes these patients end up on mechanical ventilation. When they do, we know that their compliance is going to be poor. Am I going to start them out on the 8 mLs per kilo? Probably not. When you are bagging to hyperoxygenate that patient prior to intubation, you will feel how hard it is to bag that patient. If it is really hard to bag that patient, most likely you don't need to start at 8 mLs per kilo. You could probably start at 7, even 6 mLs per kilo, so that we can get the patient the most appropriate settings when it comes to mechanical ventilation. What do you think their PF ratio is going to be? If their PF ratio is less than 200, I know that oxygen therapy alone is not going to work. So what are my PEEP settings going to look like? Am I going to use lower PEEPs? Am I going to use higher PEEPs? What's that going to look like? Be thinking about this when it comes to how this is going to impact what decisions you're going to make when you have this type of patient at your bedside. Lastly, what's your hysteresis going to look like? Is it going to be upright? Is it going to be normal? Or is it going to be laying down flat? What's that going to look like? And how are you going to help your patient through what you are analyzing, what you're assessing? What kind of mask do we wear? Do we wear for airborne or droplet precautions? If you go back and you look at the patient assessment or the patient presentation slide, I gave you a hint. The provider is wearing the appropriate mask. Go back and look at it if you don't know the answer to this question. Procedures that put us at a higher risk of contracting TB are going to be intubation, sputum induction, bronchoscopy, CPT, aerosolizing medications, irrigation of a TB abscess, and even the autopsy of a cadaver with untreated TB. All of these will increase our risk of contracting TB. When you look at it, intubation, if you're using a laryngoscope, you're down there, you're face to face, mouth to mouth with that patient almost. And that puts us at risk of being exposed to some of those aerosolized particles. If I'm doing a sputum induction, I'm doing something that will induce a cough. They're going to create these aerosolized particles, and I have to do what I can to protect myself. Same thing with aerosolizing meds and being a part of the bronchoscopy team. What are we going to do to protect ourselves? What are we going to do to make sure that we fall into compliance with all of the regulations when it comes to TB? We're going to use what's called a negative pressure room or an air room. It is an airborne infection isolation room. This is an air room, and the NBRC may call it an air room and not a negative pressure room. What this does is it creates a more negative pressure inside my room compared to the hallway and the surrounding rooms. And we know through physics that pressure or air goes from a high concentration or a high pressure situation to a low pressure situation. It's going to want to move that way. So I don't want any of the air that's in my room to escape going out into the hallway or into other patients' rooms. So I want to make sure that I create and keep that negative pressure, that negative atmosphere in my room, so that the atmosphere from the hallway, so that the atmosphere from the other rooms come into my room, and then they're evacuated through the vent system in my room, where they are filtered and they're cycled before they are evacuated out into the atmosphere. So in order for me to maintain that negative pressure in the room, I've got to make sure that the windows are closed. I've got to make sure that the door stays shut. That if I open the room, that I close the room. That's some of the big things that we have to do when it comes to taking care of patients that are in these negative pressure rooms or these air rooms. Things that we want to be mindful of when we're talking about discontinuing or moving these patients out of a negative pressure room is if the patient has had TB completely ruled out. If that patient does not have TB, then they don't need to be in a negative pressure room. If they do, or they have been diagnosed with TB, then they need to be on anti-TB medications for about 4 to 7 days. And so this anti-TB therapy, and they need to have 3 subsequent negative AFB smears that will allow me to move them out of a negative pressure room. When it comes to reporting, I need to report any cases of TB promptly to my local public health department. This way I can get case management involved. We can do any sort of investigation that we need to. Perhaps there was a healthcare provider that was not protected when they came in to treat this patient. It could happen. They're not saying you did anything wrong. They're just wanting to make sure that everybody is protected who came in contact with this patient. This also allows us to plan any outpatient follow-ups that this patient's going to need. Remember, they're going to be on 6 months to 9 months worth of medications and for a prolonged period of time. The CDC and OSHA are key players in tuberculosis. They are there to monitor any exposure risk to healthcare workers and to monitor the incidents themselves. So it's, again, not to get you in trouble, but to keep a finger on the pulse of the situation with anybody that has tuberculosis. Being a healthcare provider, you've got an increased risk of being exposed to TB. Even folks that are doing the autopsy, it's part of the game. It's part of what you're being called to do. You never know who's walking into your hospital and what they have. It's not going to change the way that I take care of you. It's not going to change what I do, but I do need to make sure that I'm doing the right thing by reporting any exposure that I may be subject to or another healthcare provider may be subject to. Again, the high-risk areas are going to be chronic institutions, jails, homeless shelters, nursing homes, those facilities. Be cognizant of those patients when they come into your facility. Anytime that you're assisting with a bronch, you're suctioning, or you have a tracheostomy patient, again, be cognizant of what's going on because you never know what that patient has until you get a definitive diagnosis. So lots of information, lots of good information when it comes to tuberculosis. We're going to jump into a new unit. Like I said, this is our more complex disorders and diseases. But when it comes to tuberculosis, remember those risk factors, remember that clinical presentation, and we have to do everything that we possibly can to protect ourselves, to protect our patients, and to protect our loved ones. So I hope you guys got all of this information. This is really good stuff. We'll see you on the next one where we talk about lung cancer.